So we're going to talk about a common clinical entity, tendinopathy. While tendinitis is generally painful, we do not see inflammation on histology, and so tendinitis is more correctly called tendinopathy. I have prepared this talk together with Dr. Christine Yin, who is one of the hand surgery fellows at Baylor College of Medicine in Houston, and I am David Netcher. We will cover some common tendinopathies as well as some interesting but less common ones. Tendinitis is, as a group, a very common set of conditions and is seen on a daily basis to the primary care physician as well as the specialist. A pediatrician is equally likely to see a trigger thumb, as is a geriatrician. Obstetricians may see young nursing mothers with sequovein stenosing tenosynovitis. The active young adult may present with tennis elbow. Even though these conditions are very common, they are often ill understood. We will provide some unifying definition. Pain is often the presenting symptom, but we will review general terms of diagnosis. Anatomy is key, not only to understanding the type of tendinitis, but also its treatment. Amongst others, we will discuss trigger finger sequovein intersection syndrome, exertional extensor tenosynovitis, tennis elbow, and true inflammatory tenosynovitis. There's still a lot of confusion over diagnosis and treatment. So much so that we don't even know how to spell it correctly. Tendon is spelled T-E-N-D-O-N. So why do we not spell it tendonitis? It seems that tendinitis or tendinopathy with an I are equally correct. As we go through the various conditions, we will see that for trigger finger, sequoveins, and epicondylitis, neither acute nor chronic inflammatory changes are seen on histology. So most of these conditions are best named tendinopathy and not an itis. Broadly speaking, there are three groups. The first is where a tendon travels through a non-forgiving, non-expansile fibro-osseous tunnel that is encased by rigid side walls. These are trigger finger and the various tendinopathies about the wrist, such as sequovein and flexor carpi radialis tendinopathy. The next group is where a tendon or muscle either originates from or inserts into bone. The bone soft tissue junction is called an enthesis, and hence this group are called enthesopathies. They may occur at the proximal muscle origin, such as tennis and so-called golfer's elbow, which are lateral and medial epicondylitis respectively, or at the distal insertion, such as the biceps and triceps at the elbow, or the ECRB and ECRL tendon at the wrist. There may be a traction periosteal reaction leading to a bony protuberance, or a so-called traction apophysis. We see this at the wrist especially with the kissing carpometacarpal boss. Finally, there are true inflammatory conditions that may present with more chronic problems, or sometimes acute inflammation, appearing almost like a clinical infection that occurs especially with calcium hydroxyapatite deposition disease. Getting onto the diagnosis, most of these conditions are painful. There's often a history of overuse, such as sports, gym, or work. There is local tenderness and often local swelling due to edema. One differentiates between ligament and muscle and tendon conditions by ranging the joint both actively and passively, as shown in the following cartoon. A muscle or tendon actively moves a joint. Thus, active motion of the joint towards the site of injury elicits pain, whereas passive motion in that direction will take tension off the injury and will relieve pain. In contrast, any movement away from the site of injury, either passive or active, will be painful. Ligaments, on the other hand, are passive restraints of joints. Thus, any motion away from the injury will be painful, and any motion towards the injury, either active or passive, will relieve pain. The only difference between a partial ligament tear or sprain and a complete tear is that one may get a sense in the latter of total joint instability, as seen on the right. This then is the basis of the Eickhoff or Finkelstein test for de Quervain. Any movement away from the source, in this case, ulnar deviation of the wrist accentuated by clenching the thumb, is exquisitely painful. On the other hand, active thumb extension will also be painful. The locations of the various fibro-osseous tunnels responsible for entrapment tendinopathy are shown in these next pictures. On the left, the site of trigger finger is at the green dot in the distal palm. FCR and FCU tendinitis are respectively the red and black dot. In the middle picture, the yellow dot close to the radial styloid depicts the site of the commonly occurring de Quervain tendinopathy, and the gray dot, proximal and dorsal, is the site of intersection syndrome. Finally, on the dorsum, in the right picture, the black dot is for ECU tendinitis and the blue for intersection syndrome, while the oval is centered on exertional extensor tenosynovitis. At the dorsum of the wrist, the extensor tendons are directed through channels lined by synovium and formed by the extensor retinaculum. This retinaculum is subdivided into compartments, 6 in all, as we go from radial to ulnar. These compartments not only enhance the mechanical advantage of the tendons, but guide the tendons along their respective paths, independent then of wrist position or movement. This structural and functional organization can, however, cause problems as the tendons travel through narrow tunnels. These fibro-osseous tunnels are numbered 1 through 6 from radial to ulnar, starting with the first and one of the narrowest that contains both EPB, which is extensor pollicis brevis, and APL, abductor pollicis longus, and is the site of de Quervain disorder. Each one of these compartments has nonetheless been implicated in symptomatic tendinopathy. The extensor retinaculum with contained tendons is again shown in my cadaver dissection. The first compartment and site of de Quervain disorder over the radial styloid prominence is clearly seen in the middle picture and marked by the metallic probe. These compartments are readily seen on wrist MRI, with the 6 dorsal compartments and the flexor tendon in the carpal tunnel. Incidentally, this MRI was done because the patient had radial-sided wrist pain and actually has synovial proliferation at the first compartment. However, MRI is not usually necessary to diagnose de Quervain. There's also a fibro-osseous tunnel at the flexor side of the digits. Here we call the restraining ligaments pulleys, but they are really like a retinaculum. They direct the flexor tendons on a curved trajectory when the digit bows into flexion. In the thumb with 2 phalanges, there are 3 annular pulleys. The fingers are a little more complex, sometimes with 5 annular pulleys, and there are 2 flexor tendons as seen in my cadaver dissection on the right. Tendinitis or impingement may occur not only in the fibro-osseous flexor tendon sheath pulling system, but occasionally at the separation of the FDS tendon as the FDP passes through these. Next, we will review the histology of muscle or tendon insertion to bone. Those who recollect their molecular histology from the long lost past will remember the so-called Sharpey's fibers, which are the anchoring collagen fibers merging into periosteum and bone. The enthesis is this point of attachment into bone. There is often a deeply invaginating synovial sac that ensures a smooth gliding surface of tendon on bone. Consequently, it is easy to understand how symptomatic patients may have an associated small ganglion cyst, which is really just a reactive synovitis. The last little bit of anatomy to review to complete the understanding of these enthesopathies is the origin and insertion of the flexor and extensor muscle. On the left, you can see that the highlighted flexor muscle mass, made up of flexor carpi ulnaris or maris longus, flexor carpi radialis, and pronator curis, have a large originating footprint at the medial epicondyle. This is the source of medial epicondylitis, or so-called Golter's elbow, whereas the more common lateral epicondylitis, or tennis elbow, has its source from the common origin of all the extensor muscles of the wrist and fingers that are highlighted on the right. Finally, the wrist extensors, made up of ECRB and ECRL, extensor carpi radialis brevis and extensor carpi radialis longus, insert distally at the carpo-metacarpal junction and may result in a fairly common distal insertional enthesopathy. We will now discuss some of these conditions individually, and we'll start with trigger finger, which is the most common. As previously mentioned, histopathology actually does not show any inflammation at all, but a chondroid metaplasia is the first annular or A1 pulling of the flexor tendon sheath. The pulleys appear hypertrophic, and there are chondrocytoid cells in the tenosynovium. There is pain with a specific motion, in this case finger flexion. Because of the jamming effect of the tendon moving within the flexor tendon sheath, there may be a catching sensation, finger stiffness, or even finger flexion contraction. For some reason, these symptoms of achiness and stiffness may be worse in the morning, being confused with arthritis. This limited joint mobility may be especially prominent in diabetics and may be a potential contributor to the so-called diabetic chiroarthropathy. There may be localized swelling in the distal palm at the base of the affected finger, and this may be due to a synovial reaction, a reactive ganglion, or a so-called retinacular cyst, or simply a mechanical effect of the tendon bunching as it squeezes through the origin of the A1 pulley. In pediatric trigger thumbs, this nodule is characteristically prominent and is called Notta's nodule. It is due to a size mismatch between tendon and sheath. The origin of the flexor sheath at the A1 pulleys is actually in the distal palm at the base of each finger. You can confirm on yourself if you flex the fingers, the bend actually occurs at the transverse palmar crease. So the site of tenderness and possible swelling is palpated by the examiner in the distal palm. So there are pain and tenderness on palpation at the A1 pulley of the affected digit. There may be palpable catching or triggering as the finger goes from flexion to extension. The Quesnel grades rank the severity from normal movement through an uneven shuddering finger movement to locking that can be corrected by active and forceful finger extension, and then locking in flexion that can only be corrected by passively manipulating the finger with the other hand. And finally, if a fixed flexion deformity occurs. Treatment ranges progressively from immobilization, especially at night, to prevent the finger from flexing down. Use of NSAIDs, even though this is not an inflammatory condition, local steroid injection, and finally surgical release of the pulley, and sometimes resection even of a slip of the FBS tendon to decrease tendon bulk. There are two suggested ways of immobilizing the finger and preventing the clenched fist position, especially at night. The lollipop ring splint, seen on the left, is comfortable to wear and restricts flexion at the MP joint, while an alternative splint is to restrict motion at the DIP joint. This latter can simply be a strapped-on aluminum foam splint across the DIP joint, or a prefabricated stack splint, as is shown on the right. When injecting steroids, the injection is done at and around the A1 pulley in the distal palm. The more commonly described injection site is the proximal X at the flexor sheath origin. However, this is quite a painful site to inject. I draw and sketch diagrams often to explain things to patients, as I am a visual person. I drew the sketch on the left. It takes me 30 seconds to draw, and the red arrow marks the digital palmar crease at the base of the affected finger. That is the distal X on the palm on the right. If the needle trajectory goes vertically down until one meets resistance, then one is against the bone of the proximal phalanx and can only be within the flexor tendon sheath. Then inject slowly. If resistance is met, withdraw the needle slowly and cautiously until the syringe plunger can depress with ease. If there is resistance, then one might be in periosteum or even in tendon substance. These are the items one needs for injection: alcohol swab, xylocaine, steroid solution, 19-gauge needle to draw up. Tuberculin syringe comes with a short half-inch 27-gauge needle, excellent for the actual injection, and protective gloves. I mix half a cc of xylocaine with half a cc of water-soluble steroids such as dexamethasone or celestone, which is betamethasone. The opaque or milky steroid solution, such as Kenalog, should probably be avoided, and I will explain later. This then shows the tuberculin syringe that comes with a pre-packaged short needle of 27-gauge size. A skinny needle makes for a less painful injection that is also less likely to spill into surrounding tissues that may occur with a thicker gauge needle. This then is a video showing a patient of grade 1 triggering with a catching finger, but not locking. The next video shows the technique for steroid injection. I have marked 2 X's as in the previous picture of the hand, but will inject at the more distal site. The slow injection is less painful and stop and withdraw slightly if one meets resistance. Next, we will look at the published evidence for efficacy of steroid injection for trigger finger, particularly as it pertains to severity and duration of symptoms, presence of associated comorbidities such as diabetes and osteoarthritis, the accuracy of injection as to whether one is actually within the flexor tendon sheath, the type of steroid used, the number of injections given in serial fashion over time, and even the affected digit. The most favorable outcome for cure is obtained with trigger thumb. The efficacy decreases with repeated injections, so that beyond 2 injections, there is a tailing off as to whether a 3rd injection will then be effective. My practice is to inject once and then bring the patients back in 4 weeks. A 2nd injection may then be tried. However, beyond that, a 3rd injection is then unlikely to be successful, not to mention the potential likelihood of complications also rises with repeated injection. There is no relationship between potential efficacy of injection and either severity or duration of symptoms, or with the presence of a nodule. In the presence of diabetes mellitus, there is overall efficacy neuropathy of about 50%, but is 66% in non-diabetics. There's no relationship to osteoarthritis as a comorbidity. Finally, there are good studies that show the injectate does not have to be precisely intrasynovial. When using Decadron, which is water-soluble and is dexamethasone, there is seemingly no difference from the fat-soluble Kenalog or triamcinolone. While triamcinolone had a more rapid onset, it seemed to overall be less durable. The disadvantage for me of using Kenalog is that it is fat-soluble, and because of that, it lingers in tissues and is more likely to result in a complication. Finally, in type 1 diabetics, steroid injection has been quoted by some as being ineffective, though most of us will still try an injection. One must warn the diabetic patient, even though the steroid is injected locally, that there could be a transient rise in blood sugar. What then are potential soft tissue complications of steroid injection? While infection and tendon rupture have been described, they should be a rarity. Vitiligo, fat atrophy, and dermal thinning can occur. The vitiligo may or may not reverse after months. These potential complications are also more likely when injecting for Decwervane or tennis elbow than with the trigger finger. One can reduce these risks by injecting precisely and not by fanning out with the injection. Using a small bore needle, do not continue injecting as the needle is withdrawn to avoid leaving a tract of injectate. And use water-soluble steroids to avoid the depot effect of fat-soluble steroids. Finally, if the non-operative measures fail, one proceeds to surgery, which can be done under local anesthesia. The A1 pulley is incised and it is highly effective. Some patients may even elect to go straight to surgery if they do not desire waiting out the effects of non-operative measures. Though not universally practiced, some even do a needle percutaneous pulley release in the office, whose safety and efficacy are enhanced by ultrasound guidance. A brief word about pediatric trigger digits. While not always necessarily present at birth, it has been called congenital trigger digit, and most commonly affects the thumb and may be bilateral. While axial triggering may occur, most frequently the thumb IP joint is locked in flexion. Up to a year of age, there is a possibility of spontaneous resolution. Generally, beyond that time, surgical release is done for pediatric trigger thumb. Next, on to Decwervane stenosing tenosynovitis. It occurs at the first dorsal compartment of the extensor retinaculum at the wrist joint, just at the natural prominence formed by the radial styloid. It is marked on the arm on the right. The less common but sometimes confusing intersection syndrome occurs more proximally and dorsally, where the tendons of the first compartment cross over those of the second compartment. Again, on histology, we see an absence of either chronic or acute inflammation. There may be a history of chronic overuse, especially with the thumb up position, or twisting or wringing. Hence, a young mother cradling her baby, or washerwoman wringing out clothes. There are local swelling and tenderness. There may be palpable crepitus and triggering with some motion, and there may even be a small reactive ganglion cyst. There are three well-recognized clinical tests. Resisted active thumb extension will cause pain. Remember, active motion towards the site causes pain, whereas passive motion will relieve pain in that direction. On the other hand, motion away from the site will cause pain, and in this case, it is often very intense. I will next go through the Eycock-Finkelstein and radial synergy test. Again, grasping the thumb and ulnar deviating the wrist will often cause the patient to sit bolt upright from a startling pain. This test may, however, also be positive with intersection syndrome, some basilar osteoarthritis, and radial sensory nerve entrapment called Wartenberg phenomenon. So while it is a very sensitive test, it is not as highly specific for de Quervain. So here we have the three tests. On the right is the ICOP test, where the patient grasps the thumb and then the wrist is ulnar deviated. This is often mistakenly called the Finkelstein test, which is originally described as the examiner passively manipulating the thumb and wrist, as shown in the middle. Hot off the press, and still in electronic version preceding actual print publication date in the journal Hand, is the radial synergy test. The examiner grasps the three middle digits, and then the patient abducts the little finger against resistance. If you do this on yourself, as you can see in the left-hand picture, the thumb synergistically tenses into extension. This test, as with the ICOP and Finkelstein test, is highly sensitive, but is far more specific for de Quervain than the other two tests. Non-operative treatments include thumb and wrist immobilization, NSAID, activity modification, and up to 2 steroid injections. The combination of splinting and steroid injection has been found to be far more effective than either individually and alone. This MRI, with the arrow pointing to the first dorsal compartment, shows the synovial response in a patient with de Quervain. But again, MRI should seldom be necessary to make this diagnosis. This shows the correct design of a thumb splint, immobilizing splint, either a custom-made one on the left or a prefabricated one on the right. The patient will be more compliant with the splinting if the IT joint of the thumb is left free, enabling more functional use of the thumb. This, on the other hand, is a carpal tunnel splint. It does not support the thumb, and so is not effective for treatment of de Quervain. Steroid injections are highly effective, especially when combined with splint immobilization. Because this tendon compartment is superficial, there is greater potential for steroid injection complications. This then shows steroid injection for de Quervain. Keep the needle deep until the full volume is injected. Surgical treatment involves release of the retinacular sheath in an operating room. It can be done under local anesthesia. There is potential risk of injury to branches of the superficial radial sensory nerve. Sometimes there may be two separate compartments for the ETB and APL tendons, and symptoms will persist if the surgeon fails to recognize this and releases only one of those subcompartments. Next, we will go on to intersection syndrome, which is much less common than de Quervain, but may be confused for de Quervain and may even coexist with de Quervain. It is more proximal and dorsal than de Quervain. Again, it occurs with repetitive activity and seems to be prevalent among competitive rowers. There often is palpable crepitus. It occurs where the ETB and APL tendons cross the wrist extensor. These are the sites for injection of de Quervain and intersection syndrome, and also in the top picture, the sites for surgical release to include both the retinaculum of the second dorsal compartment and at the site of crossover of the tendon. Treatment is same chapter but different verse. Activity modification, immobilization by splinting, NSAID, steroid injection, and surgery. The injection is shown for the intersection syndrome. Staying at the wrist, we will talk about another wrist swelling that is quite common, but not always symptomatic. The patient may come with an asymptomatic wrist bump, looking for a diagnosis. In textbooks, the so-called carpometacarpal boss finds its way into chapters on ganglia, because there's often an associated ganglia, and also in chapters on osteoarthritis, because there are bone spurs, but they are not osteoarthritic. In fact, these bony excrescences occur at the carpometacarpal junction at the base of the index and middle finger metacarpals and are highly likely due to traction at the insertion sites of the ECRB and ECRL tendons. Thus, this is an enthesopathy. Because of the curvature of the wrist, the bone spurs are best seen not on a true lateral or AP radiograph of the wrist, but on a 30-degree supinated view. That puts the bone outgrowth on profile view. They are often painless, but if painful, one tries a sequence of immobilization, steroid injection, and finally excision. The pain may be aggravated when taking axial load on a fully extended wrist. Just a reminder of the distal insertions of the ECRB and ECRL tendons and the sites of the so-called carpometacarpal boss. An entity that I see moderately commonly as a hand surgeon is exertional extensor tenosynovitis that affects the portodorsal compartment of the common finger extensors at the extensor retinaculum. There is painful swelling just distal to the extensor retinaculum, secondary to a proliferative reactive synovitis. This discomfort is most pronounced when simultaneously extending the fingers and wrist. Indeed, if one then flexes the fingers with the wrist still extended, the pain on the extended wrist is relieved because the synovial impingement on the distal edge of the retinaculum is then carried distally. One needs to exclude an infectious or inflammatory arthritis. The tuck sign is seen as the skin invaginates and is thrown into a wrinkle when the wrist and fingers are extended and the distal synovial proliferation is thrown into prominence by abutment against the retinaculum distal edge. On the left is an ultrasound image and the right an MRI showing the synovial proliferation in the portodorsal compartment in a patient with exertional extensor tenosynovitis. Treatment again involves rest, activity modification, steroid injection, and finally surgery. Surgery involves not only tenosynovectomy, but also excision of a strip of distal extensor retinaculum to reduce the abutment phenomenon. Extensor pollicis longus tenosynovitis results not only from friction within a fibro-osseous tunnel, but also abrasion around the oblique angled core by the orientation of listed tuberosity on the radius. There are pain and swelling, often crepitus. One needs to exclude an inflammatory arthritis such as rheumatoid. While non-operative measures may be tried, one often proceeds more directly to surgery because of the greater risk of attritional tendon rupture. This may occur at the distal radius fracture, often surprisingly non-displaced fractures, or with repetitive activity, the so-called drummer boy palsy. This picture illustrates the oblique trajectory that the extensor pollicis longus takes, and surgery involves not only release of the retinaculum, but actual displacement of the tendon out of the groove around listed tubercle. There are also fibro-osseous tunnels on the volar side of the wrist. The flexor carpi radialis tendon travels through its own tunnel at the flexor retinaculum. Again, there may be swelling and pain along the tendon. Resisted wrist flexion on this occasion, with palpation along the tendon causes pain. Treatment once again involves immobilization, steroid injection, and ultimately surgery. This picture shows how the FCR tendon is actually embedded in the flexor retinaculum, and peritendinous osteoarthritis may even result in rupture of adjacent tendons. On the right, we see a surface view of the FCR tendon going through its fibro-osseous tunnel. This demonstrates the clinical test for FCR tendinitis with resisted wrist flexion and deep tendon palpation. Next, we will move to the elbow, where lateral epicondylitis is 10 times more common than medial epicondylitis. This is an enthesopathy, and tennis elbow is thought to result from a tearing in the common ECRB tendon that results from mechanical overload and ranges from microscopic to gross tears. With lateral epicondylitis, there is pain with active resisted wrist extension, and pain is reproduced with full elbow extension and the wrist passively flexed. There's localized tenderness at the epicondyle, and with severe medial epicondylitis, this may be associated with ulnar nerve symptoms as well. This shows the point of maximum tenderness for lateral epicondylitis. The elbow X-ray may show a periosteal reaction by the red arrow and a so-called traction apophyseal reaction and the absence of any elbow arthritis. Again, histopathology is devoid of inflammatory changes but shows degeneration and reparative processes. 90% will resolve without surgery. However, this process may take many months, and these are generally active patients desiring to get back to full activity, and the prolonged recovery will test the patience of both the treating physician and the patient. Activity modification and end stage play a role. A simple so-called counterforce Velcro brace helps. It offloads the common extensor muscle origin. And unlike other tendinopathies, steroid injections for tennis elbow are said to be of questionable value. Therapy plays a greater role than with other tendinopathies, both with use of various modalities and also with progressively modulated stretches and then strengthening. This is the counterforce Velcro brace applied over the proximal muscle belly, just distal to the lateral epicondyle, with tension adjusted to patient comfort. The Orthopedic Academy website has the progressively modulated therapeutic exercises graphically illustrated. Finally, if recourse is made to surgery, which can be done arthroscopically, then therapy needs to progress through the recovery period. We reach an end with the true inflammatory tendinitis and the tenosynovitis. Chronic proliferative tenosynovial conditions, such as gout and pseudodiet, amyloidosis, sarcoidosis, and rheumatoid arthritis, may cause triggering stiffness at any of these sites mentioned, but may also be associated with carpal tunnel syndrome. There are, however, some acute inflammation that can present with exquisite pain in tendons, pain with joint motion, and inflammation with redness and swelling. Gout is, of course, the great mimicker and can do this, but there is the condition of acute calcific inflammatory tendinitis caused by calcium hydroxyapatite deposition. If recognized and correctly diagnosed, they will resolve spontaneously with NSAIDs and rest. I was consulted concerning this patient who was thought to have a cellulitic infection. A clue to the correct diagnosis is the very severe pain. Her X-ray is shown on the left with the amorphous peritendinous calcific deposit. This calcium will usually resolve as the clinical condition improves. Other clinical cases are shown with the deposit at the radial styloid in the middle and at the finger MP joint on the right, mimicking an acute arthritis. My patient did actually have an MRI showing the tremendous peritendinous inflammation. In summary, I have discussed the various types of tendinopathy, subdividing those that occur in a fibro-osseous tunnel and those that are an enthesopathy. I make no excuses for using the word tendinitis where I might have more correctly called it the tendinopathy. However, old habits and common usage still use the word tendinitis. We have also seen that there may be true acute tendinitis. The general treatment principles are the same for all to include activity modification, controlling comorbidities, especially having diabetes under control, specific splint immobilization, steroid injection, and then surgery where appropriate. There are a few exceptions. One will probably proceed to surgery quicker with EPL tendinitis out of concern for tendon rupture if untreated. Steroid injection may not be as beneficial for epicondylitis, and most epicondylitis will eventually respond to non-operative measures. I do have references listed, especially those where we have some quite good evidence-based literature, especially for the common trigger finger